Hi, everyone. I'm coming to you from the province next door. Yes, I'm in Calgary right now. I go to the University of Calgary. I am a graduate student here in orthopedic trauma, and I wanted to thank you for having me today to talk about my research. So this is some of my preliminary data that's looking at the differences in hypercoagulability profiles between patients with pelvic fractures and patients with acetabular fractures. All right. So here, I just want to make sure. So it's well known that orthopedic fractures increase the risk for the development of blood clots, or venous thromboembolism, VT for short. Major fractures, such as those that occur within the pelvic ring, which is seen in the top X-ray image, and fractures of the hip socket, which is also called the acetabulum, and that's in the bottom X-ray there. They have especially high rates of VTE, despite thromboprophylaxis, or that blood thinner medication that is prescribed to prevent blood clots from forming. However, the duration of hypercoagulability, or that increased risk for blood clotting, with pelvic and acetabular fractures is unknown. So my research is investigating for how long that duration remains. I'm doing that by using a whole blood point of care test called thromboelastography, long name, more simply called TAG. Maximal amplitude values, or MA values, from this TAG analysis measures the strength of a clot, and it's used to quantify hypercoagulability. Values greater than or equal to 65 is known to be associated with a 3.7-fold increased risk in in-hospital VTE for trauma patients, such as those with pelvic and acetabular fractures. Now, even though pelvic and acetabular fractures are different fracture types, these populations are presented together within the literature. One thing I am particularly interested in is to utilize TAG to compare hypercoagulability profiles between pelvic fractures and acetabular fractures. So this is a prospective cohort study of adults with surgically treated pelvic and acetabular fractures who are admitted to Foothills Medical Center here in Calgary. It is a level 1 trauma center for all of southern Alberta. And these patients have serial TAG analysis performed at time points determined a priori for up to 3 months following their surgery. Exclusion criteria includes being on current therapeutic anticoagulation, known bleeding disorders, or conditions that we already know increase the risk of clotting, such as cancer and pregnancy. Now, all patients in our study have received standardized thromboprophylaxis postoperatively. Here I've outlined the blood collection schedule for this TAG analysis. It begins when a patient is admitted to hospital throughout their hospital stay, and then at 2, 4, and 6 weeks, as well as 3 months post-surgery. Here I've outlined patient demographics and baseline characteristics. In this cohort, we've had a total of 33 patients. They had a mean age of 47, and most of the cohort consisted of males, with only 10 females. We also saw that there was a pretty even split between pelvic fractures and acetabular fractures at 15 and 18 respectively. Now, overall, as one population, like it's presented in the literature, we've seen that practically all patients are still hypercoagulable at 2 weeks after surgery. Come the end of thromboprophylaxis use at 4 weeks, still half of the patients were hypercoagulable. And then almost a third at 6 weeks and 14% still at 3 months after. So we've discovered that there still remains this high rate of patients that are at this increased risk for blood clotting come the time that they are discontinuing their thromboprophylaxis. So here I've outlined the patients who did have a VT event. In this cohort, we had a total of 7 patients, so that's a 21% event rate. We had a mean MA value of 68.2, plus or minus 4.8, at the time that's closest to their VTA diagnosis. 2 of the 7 patients who had VT events, or 29%, had pelvic fractures, and then 5 of the 7 had, or 71%, had acetabular fractures. Now here's a visual comparison of serial MA values between pelvic fractures seen in purple and acetabular fractures in green. The horizontal axis, we have our time points up to 3 months. Vertical, we have the MA values. The dotted line at that 65 and the shaded above it is our established hypercoagulability threshold. Now, visually, we can see that they both follow overall similar trend and that acetabular fracture patients in green have slightly higher values at the majority of our time points. Well, we can see this in the graph. There was no statistically significant difference in the MA values at the time that was closest to the VTE diagnosis between our 2 patients with pelvic fractures and our 5 patients with acetabular fractures. Now, based on my results so far and the small sample size, further research is required to evaluate potential risks that may differ between these 2 populations, our pelvic and our acetabular fractures, to determine if there may be a need for injury-specific thromboprophylaxis. I'd like to thank my supervisor, orthopedic surgeon scientist, Dr. Prism Schneider here at the University of Calgary, and acknowledge our Foothills Orthopedic Trauma Service and our entire research team. Thanks. Question?
Questions?
Can I ask a question, Dana?
Yeah.
Hi, it's Mark Yazer here from Pittsburgh. Nice presentation, Ashley. We're doing a similar look at changes in the ROTEM, which is the other rotational thromboelastogram device of patients with different types of massive bleeding, and we're seeing quite a big difference between different types of patients. I wonder, what was your hypothesis a priori? Like, why would you think there would be a difference between these 2 very specific fractures?
That is an excellent question. So my hypothesis is that I believe acetabular fracture patients will have higher VTE rates and higher hypercoagulability profiles with TEG. Now, my reasoning behind that is that in general, acetabular fractures, the surgery itself takes longer. So, more injury for the fracture itself, because typically those are a little bit more unstable from a bone fracture perspective. And then also the surgery that's required to fix an acetabular fracture versus the pelvic ring, it's typically a longer surgery. So, we have a larger cut when we make the incision for the surgery itself. It just takes longer, more of that vessel damage and injury.
Wayne?
Is this working? Oh, it is working. Hi, great talk, actually. I have a somewhat technical question. So I've been working a lot with ROTEM, and I think TEG is similar in the way that you need to initiate the coagulation with some sort of a coagulation factor. In our case, it's like tissue factor, for example. I'm wondering which coagulation initiator do you use in your TEG assays?
Yeah, that's a great question. So I actually don't know if I put an image of it on now that I think about it, but ours, there. We're using the TEG 6S machine. So it has the cartridge already done, and it has tissue factor activated in one of the, there's essentially 4 parts to it that have different, substances. I don't want to get too technical into it, but it's already in a cartridge that's already done. And one of them is tissue factor. We also have the clay that Kellen clay that also is part of that. So it's really great though, the TEG 6S, because we have less user error because it's a little bit easier, I believe, than what you guys are working with to use. And we're hoping eventually to potentially use it bedside. So I'm interested also to know a little bit more about what you guys are doing from that perspective.
Thank you so much.
Yeah, thank you.
Question up in the back.
Can you hear me okay? Okay.
Yes, I can.
Great. So I'm wondering, you showed your age range for the patients, and I think it was something like 47 plus minus 20 or so. So I'm wondering, these questions are related to like age and cause of fracture, right? So presumably if someone's older and has maybe more osteoporosis or whatnot, that's going to be a different sort of patient than someone who's in their mid to late 20s and hits a tree skiing or something, right? So I'm wondering if you're going to try to stratify your comparisons like that for VTE.
Yeah, that is an awesome question. So we definitely do see that. We have a bimodal distribution, essentially, of our age and mechanism of injury. So you're spot on. We have patients who are older who, unfortunately, you know, as we age, age is a known blood clotting risk factor, but also, yeah, there's other elements, osteoporosis. They might potentially, you know, have a low energy mechanism, so like a fall from ground level that causes their fracture. On the flip side, we also have these younger individuals who, yes, sports injuries, car accidents, horseback riding here in Alberta is very much a thing. So we're looking at that, and I'm hoping to be able to stratify that based on, you know, mechanism of injury as well as age. We are kind of looking at, you know, obviously comorbidities and if they have osteoporosis, if they're on bisphosphonates for bone health, all that sort of stuff. It's in the process for sure. So thank you for that.
Okay, we have one question coming in from Tyler Smith, who he's saying that maximum amplitude in ROTEM correlates with the Klaus fibrinogen levels, and he's wondering if you performed fibrinogen levels, and if so, did they show the same postoperative trend?
That's a great question. So for this, I just was focusing on my MA value. I am also capturing like platelets, red blood cell counts, PTT, PT, INR, D-dimer, also inflammatory markers to be able to look at later. I just honestly have not quite gotten there yet.
Okay, thank you, Ashley.
Yeah, thank you.